everyone. I welcome you all to this session on more aspects of diabetes management. And for that, I would like to invite the speaker today, Dr. Vijay Panikar, who is a famous diabetologist. He is a consultant at Leelavati Hospital. He's been an ex-vice president at the RSSDI, past chairman of RSSDI Maharashtra chapter. He has more than 20 research publications in journals. He's written chapters in textbooks and medicine updates. He's also a co-author of the RSSDI recommendations for diabetes management. So I welcome you, sir, and over to you.
Thank you. Thank you for a very kind introduction at the outset. I must congratulate Diabetic India team, Bansi, Manoj, Rajiv, and the entire team for a wonderful academic session that they have dished out to the delegates. Thanks to their hospitality. The topic given to me is the place of other oral anti-diabetic agents in the era of SGLT2. Which, when, and why? See, today SGLT2, if you see that this is the 2022 ADA guidelines. If you look at the first column, there is no pointer here. The first column, that if you have an associated or ASCVD high-risk patient, what is recommended is after metformin start an SGLT2 or a GLP-1. That is what all the current recommendation is. So in short, ADA has tried to make it as simple as possible, and they say independent of baseline A1C, whatever the A1C, the use of metformin, people need to be on a SGLT2 inhibitor or a GLP-1 receptor. So that is where SGLT2 is today. And why is so? Look at the EMPIRE study. 33% relative risk reduction in cardiovascular death. And if you look at SGLT2 across the board, it reduces atherosclerotic events in secondary prevention cohorts, but not in primary prevention. Mark this. But if you look at the second message, across the board for all the SGLT2 inhibitors, unlike MACE, heart failure and cardiovascular death reduction is observed in both primary and secondary prevention cohorts. So that is where SGLT2 is today. Now look, coming back to this, we looked at if you have an atherosclerotic cardiovascular disease, SGLT2 comes up right on the top. So today SGLT2 has become the molecule, and becoming generic, it has become cheap, affordable. We can give it to every patient of ours. So that's why this topic, that what else can you give with an SGLT2? The main stumbling block is hypoglycemia. So you should minimize the risk of hypoglycemia, and here there are only two molecules which will cause hypoglycemia: sulfonylurea and insulin. If you don't use them, then you are on very safe ground as far as hypoglycemia is concerned. There is no problem. Next, if you see, you don't want to have a weight gain. Which are the drugs that will cause weight gain? There are three: the sulfonylurea, the glitazones, and insulin. These are only three drugs which will cause weight gain. So if you don't use them, you are safe. But as far as glitazones are concerned, the weight gain is not a pathological weight. It is a cosmetic weight gain. Because what the glitazones do is, it reduces the visceral fat and increases the subcutaneous fat, and it has got a very good effect on cardiovascular outcome. Now the next, if you consider what they say is, if cost is a factor, then after metformin, use sulfonylurea and a glitazone. Now India is a poor country. Only 2% of Indians pay income tax. Only 2%. And how many can afford the fancy prices? So sulfonylurea, metformin. But today the scenes have changed. Now cost 2 is no longer a limitation for DPP-4 and SGLT2. So today we have 9 therapeutic classes of hypoglycemic agents. You have 7 oral. And if you see the last one, 7, oral semaglutide, very expensive. It costs 10,000 to 12,000 rupees a month for the patient. Forget that. But rest of them,
are all within the reach of the common man. And I think this today, in the last 6 months, things have so changed on the diabetic scenario for the doctors and for the patient. It's a win-win situation. Cost is not an issue, and you have all the molecules that you have which you can use. But what is the current reality of diabetes? Look at this. This is in India now today. A 30-year-old man will live up to 75. That's the statistics. But if you have this same 30-year-old guy who becomes a diabetic at 30, he stands to lose 14.5 years of his life. So when you're treating a diabetic, this is what you have to keep in mind, that you're not treating diabetes to control his sugar. You are treating him holistically so that he has a nice, healthy, long life, and that 14.5 years which he stands to lose, you can save for him. That should be your attempt. So what do patients really die of? 80% will die of a cardiovascular problem, macrovascular disease, renal failure. You go to any dialysis unit, 60% of the patients there are diabetics. And now we have another big epidemic on hand, which is just the tip of the iceberg at the moment because we are not looking into it. You do a sonography for any diabetic patient and you will see that they have got fatty liver. So this is the other epidemic that is coming. And this fatty liver is driven by insulin resistance. The UKPDS study was a brilliant study done on newly diagnosed diabetic. And what they showed was that by bringing down the HbA1c to 7, you could have very nice benefits. So look at this. This is the ADA ESD guideline of 2006. What does it say? Diagnosis, lifestyle modification, metformin. If HbA1c is more than 7, treat. If HbA1c is less than 7, no treatment. This is what was in 2006. So then came major studies that let's see if we can reduce the HbA1c to below 7 and give benefits. So there were 3 major studies done, Accord, Advance, VADT, to get the HbA1c below 6.5. And what did they find? Little benefit of intensive control. Accord, there was increased mortality, 250 patients died. So they had to discontinue the trial. So what is the big message for cardiovascular disease from all these studies? That good glycemic control does not prevent heart attack. You could still die of a heart attack with an HbA1c of 6.5. That is the big message that we know. So diabetes is not only about sugar. Blood sugar is just one aspect of it. And if you ask me, blood sugar is the one which causes the microvascular complications. The macrovascular is different. So when you're treating type 2 diabetes, you should treat the hyperglycemia. You should have a good glycemic control, which would prevent your microvascular complication. But you have to look at the dysmetabolic syndrome, which is the main thing, which everybody forgets in their attempt to, sell drugs. Nobody talks about this. They only talk of glycemia, glycemic variability, postprandial hyperglycemia. Come on, yaar. Look at this. Dysmetabolic is insulin resistance, obesity, hyperinsulinemia, hypertension, dyslipidemia, and a procoagulant state. Diabetes is an atherogenic state. You get premature atherosclerosis. So when you are treating a diabetic, what do you need to do? You need to obviously have a combination, and that's the topic. That with SGLT2, what will you combine? You want a good glycemic control, every molecule will give you a good glycemic control, the way you use it. Whether it is sulfonylurea, insulin, or DPP4, whatever. Next and most important, one of the important aspects is you want to preserve beta cells which will give durable glycemic control. Why does diabetes progress? Because of apoptosis of the beta cells. This is UKPDA study which says that at the time of diagnosis, more than 50% of beta cells are already gone. These are about 10 studies which show use of sulfonylurea. See, initially there is a good decline of HbA1c in the first year. And then you find it is going up. This is showing the progression of the disease. And why is that progression of the disease? Because the beta cells are dying, which tells you that sulfonylureas cannot preserve the beta cell. These are 8 studies using glitazones. Look, initially down, and then there is a steady HbA1c maintained for about 5 years. What does that tell you? That probably these drugs are preserving the beta cells. So why does beta cell apoptosis really take place? Most important is lipotoxicity. Of course, hyperglycemia and glucotoxicity also does. Insulin resistance will promote both these, plus have a direct effect on apoptosis. So, what is the effect of a glitazone? How does it preserve the beta cell? Forget all that. Just what is in the yellow. There is a mobilization of toxic lipid metabolites out of the beta cell. And that is what leads to the preservation of the beta cell. And that is the importance of using a glitazone. So that's as far as preservation of beta cells, we only have pioglitazone. GLP-1 analogs have been shown to have some preservative and even regenerative effect on beta cells, but still in experimental stage. Next is treating insulin resistance. We are an insulin resistant population. 83% of type 2 diabetics are insulin resistant, and this is highest in Asian Indians. All studies have shown that insulin resistance has been demonstrated in Indians even during adolescence. Professor Yagnik, who was here, has shown this, that it starts in intrauterine life. So that is what the problem is. These are the 2 major studies which have shown, Helsinki and Verona diabetes study, that insulin resistance is an independent risk factor for the prediction of cardiovascular disease. So what are the clinical manifestations of insulin resistance? Insulin resistance will cause glucotoxicity, lipotoxicity, etc. All this. Let's look at this, the clinical consequences. You have diabetes, hypertension, atherosclerotic cardiovascular disease, heart failure, sleep apnea, peripheral vascular disease, stroke, PCOS, NAFLD, and NASH. This is what insulin resistance causes. And unfortunately, we as doctors are not addressing insulin resistance the way we should. This is the ticking clock hypothesis, the Nurses' Health Study. I won't go into the details. But what this showed was that the elevated cardiovascular risk began 15 years before the onset of diabetes. So what are we talking? We are just being sugar controller without looking at the basic pathophysiology. Now, is there evidence that insulin resistance treatment will help? Yes. What will treat insulin resistance? Diet, exercise, weight loss will treat insulin resistance non-pharmacologically. Pharmacologically, metformin and pioglitazone. And these are the diabetes prevention studies which have done good results. Pharmacologically, all these studies using glitazones have done, but the IRIS study is very important. I'll show you that. What was this IRIS study? This was a study in non-diabetic patients. Non-diabetic patients who had a TIA or a stroke and who had insulin resistance. They checked their HOMA. For HOMA, you do a fasting sugar and a fasting insulin level, and there is a formula to calculate. And if the HOMA was more than 3, they labeled them as insulin resistance and put them on pioglitazone, 15 to 45 milligrams, and placebo, followed them up for 5 years. What did they find? Recurrent stroke reduced by 24%. These patients were already had a stroke. But if you look at the proactive study, stroke reduced by 47%, and that was the reason why this study was done. So recurrent stroke reduction is 24%, myocardial infarction reduced by 24%, new onset of diabetes by 52%. So this is the first time that a therapy directed purely at insulin resistance, there is no diabetes involved, gave you this kind of benefit. That is the importance of it. But look at it. This was the ad hoc analysis of the IRIS. About 2,885 patients who had pre-diabetes. They were not diabetic, but they're pre-diabetic. Either an impaired fasting glucose, impaired postprandial, or a HbA1c in the pre-diabetic range. And what did they find? Their combined stroke, myocardial infarction reduced by 40%. Stroke itself by 33%. Acute coronary syndrome by 52%. new onset of diabetes by 80%. Now, that is the benefit you get by treating insulin resistance, which no molecule, nothing, you can get your HbA1c to 5 and nothing will happen, you will die of hypoglycemia, nothing else. So this is the importance. So when you talk of treating insulin resistance, the only molecules we have is a pioglitazone and metformin. Should not cause hypoglycemia, I have already discussed, all except insulin and sulfonylureas. Should not cause weight gain. SGLT2 will cause a weight loss about 2 to 3 kilos. GLP-1 again 2 to 3 kilos, that's it. Metformin and DPP-4 inhibitors are weight neutral and pioglitazone is weight positive. It should be renoprotective. Renoprotective SGLT2 across the board. All the molecules have shown consistent and impressive renal benefits in both primary and secondary prevention. What do you mean by primary? You could be on SGLT2 and prevent a nephropathy taking place. You could have a patient who already has a nephropathy, it could be reversed with the use of an SGLT2. So that is where this was. So when you talk of renal protection, SGLT2. Cardiovascular benefits, UKPD has shown metformin, and that was the reason why metformin was really approved in the US. So SGLT2 are a good option in patients that are not meeting their glycemic control. I have already discussed about SGLT2. Which anti-atherogenic properties and cardioprotective effect. You have the proactive study, the Chicago study, the Periscope study, the IRIS study. The IRIS which I just discussed with you. Several meta-analysis and many observational studies. This is a comment by Robert Ryder and Ralph DiFranzo that pioglitazone is inexpensive, very effective at reducing HbA1c, no evidence of bladder cancer risk, and plenty of evidence of cardiovascular benefit. Other drugs which have shown cardiovascular benefit is the GLP-1 liraglutide and semaglutide. So what is the strategy? What will you combine with an SGLT2? Macrovascular damage starts many years before the onset of diabetes. Many years. Insulin resistance and its complication and beta cell preservation have to be adequately addressed for positive long-term outcomes. If insulin resistance is treated right from day one, we will see lesser macrovascular complications. Metformin and pio most durable, less weight gain when sulfonylurea is not in place. But if you add an SGLT2 to a metformin and a pio, it's a deadly, unbeatable combination. The weight gain of pio is neutralized by weight loss of SGLT2. The fluid retention of pio is reduced by SGLT2. Fantastic combination. So metformin pio gives you the best result when endogenous insulin is present. What does that tell you? That you have to start early. You don't start pio after 10 years of diabetes when all his beta cells are thakke gaye hai sir. Right from day one, the day he comes to you, unless there is a contraindication, start him on a metformin pio and metformin pio and SGLT2. When endogenous insulin, that means early in the history of diabetes, is early use, intelligent use. So what would be the ideal algorithm? What are you aiming at? You want to reduce peripheral insulin resistance, you want to preserve the beta cells, and you want to prevent diabetic complications, and you don't want hypoglycemia. So these are the molecules which you have. Metformin, glitazone, SGLT2 would be on the top of the list, right from day one. And if they don't work, you could add a DPP-4 or a GLP-1. GLP-1 is a very heavy on the pocket. I would go with DPP-4. If that does not work, if still your sugars are not controlled, you may need a slight push with a sulfonylurea. So these are the sulfonylureas you have, and among them I would say a modified release glycoside would be the best, because chances of hypoglycemia is minimum with them. If the patient has only a postprandial hyperglycemia, you would use add an alpha glucosidase inhibitor. And if after doing all this, his sugars are still not controlled, that is when you go for insulin. This would be the algorithm for treatment, and the combination with SGLT2 would be a metformin and glitazone right from day one. Thank you very much, ladies and gentlemen.
We are open to questions. So, what would be your choice for treating pre-diabetes?
See, in fact, I think 2 days back I was listening to right before we were talking about pre-diabetes. That was IDEC conference Sanjay Agarwal had organized. Listening to him. For diabetes prevention, a lot of diabetes prevention studies have been done, lifestyle modification, metformin, whatever. But he showed that period of time all of them failed. And he said, if you're going to treat pre-diabetes, it should be medication. And no molecule to treat pre-diabetes is a pyramid as of today. In all the studies, the Act now has shown almost 80% reduction in new onset of diabetes. And it maintains.
What about metformin?
We have a metformin. Metformin would be the ideal drug. But many a times you will see that this patient will go into hypo. So there you may knock off the metformin and keep only the pyro. And still some patients go into hypo and make it 7.5.
Sir, I have a question. We do get a lot of coronary disease incidence has gone up. So now intensive training, we get a lot of patients who come with an acute MI who never had diabetes before, but at the time of admission we take them to have diabetes. So they undergo angioplasty or a PTCA, and then at the time of discharge as a diabetologist, they're asked to treat them for diabetes. So do you think the SGLT2 inhibitors could be started at that time and we will have to wait?
Oh yes.
Prevention.
See, today the way situation is that I think SGLT2 should be given to every type 2 diabetic unless he does not tolerate it. And the basic tolerance is only in genitourinary infections. There is no other major concern with that. So it should be given to every type 2 diabetic whether he had an angioplasty or not. But if you have it, then all the more reason you should have it. Cardiologists have it. Promoting it.
Even non-diabetic also?
Yes, non-diabetic also there are a lot of studies to show that dapagliflozin and pentagliflozin are used in non-diabetic. Is it approved?
And amongst the SGLT2, which one would you prefer?
I think all are good. We just see which is the most economical one for the patient and use it. And I think today dapagliflozin is available in a very economical way. Should be just across the board, not an issue. All of them are good.
So would you recommend pioglitazone in PCO as a pre-diabetic condition?
Can I answer? I didn't get it.
No, would you recommend pioglitazone in polycystic ovarian syndrome as a pre-diabetic condition?
See, there are a lot of studies to show that pioglitazone is very effective in PCOS. But pioglitazone can cause an ovulation also. And can probably precipitate a pregnancy, which may not be good when pioglitazone is on board. So metformin is the gold standard for treatment for PCOS today. Pioglitazone is not used. There it is pre-diabetes, but they are not pre-diabetic in that sense. They are hyperinsulinic. Their sugars are normal. If the sugars are abnormal, then that's a different ballgame altogether. A plain PCOS is generally insulin resistant state, I agree with you. It is hyperinsulinemic, which again ideally would be pioglitazone, but there is resistance for its use. Not recommended.
So, in rare cases, we have hypoglycemic episodes, the use of metformin.
Yes. See, all these drugs, I said, main drugs which will cause hypoglycemia, insulin and sulfonylurea, which does not mean the others don't cause. They have got a 0.5, 0.2% incidence of hypoglycemia, even metformin. So, if that rare patient is your patient, you have no choice but to stop it. Thank you. Thank you very much.
So our next speaker is Dr. Anil Kumar Virmani, and he's going to be talking on diabetes prevention. He's done his MD in General Medicine, and he's a fellow of Indian College of Physicians, Indian Association of Clinical Medicine, fellow of Diabetes India. He's also published a number of chapters in API, RSSDI update textbooks, and he's a recipient of the Economic Times Healthcare Award for one of the most inspiring diabetologists in 2021. Thank you, sir. Over to you.
Diabetes India. Where is it? Diabetes India. Yeah. This one. No? Okay. Can you, right? Honorable chairpersons and dear friends, a very good morning to all of you. Yesterday we had heard a wonderful talk by Professor Seshaya on primordial prevention of diabetes, type 2 diabetes. And he was talking about how we can prevent diabetes in the future generations. Today, I'll talk about how we can prevent diabetes in the present generation. Type 2 diabetes is a complex disease that progresses through 3 states: a normal state, a pre-disease state or a critical transition state, and a disease state. The key issues here are, do all patients with pre-diabetes behave the same way? Can we identify this pre-disease state and stratify according to the risk of progression to diabetes or complications? What drives the change from pre-diabetes to diabetes? Can we prevent this change by pharmacological intervention, and whom to treat? What is the role of biomarkers, low adipectin, and other pro-inflammatory markers like higher levels of vitamin A and vistatin? Role of liver, pancreatic, and renal sinus fat. Of course, we have answers to some questions, but there are still a lot of questions unanswered. But what we should all remember, that all patients with pre-diabetes should undergo intensive lifestyle modification. Now, if you look at pre-diabetes, it is a high-risk metabolic state for diabetes. And the current definition of pre-diabetes neither reflects subphenotypes of pathophysiology of type 2 diabetes, nor is it predictive of future metabolic trajectories. The criteria was 5.7 to 6.4% adopted by AD in 2010, and the lower cutoff of 5.7 was based on modeling the estimated composite risk of developing diabetes and CVD using cross-sectional data from the 2005 to 2006 NANA study. However, there is no obvious lower threshold. The risk starts to increase beginning at fasting 82 to 87 milligram and progresses in a curvilinear fashion. Compared with the gold standard 2-hour glucose criteria 140 to 199, fasting glucose of 100 to 125 lacks specificity and results in many false positive diagnoses, whereas an A1C of 5.7 to 6.4 lacks sensitivity and results in many false negative diagnoses. The glycemia of pre-diabetes is not independently associated with CVD, but is only a risk factor for development of diabetes and its complications. The near twofold higher unadjusted risk for CVD in people with pre-diabetes is driven mainly by abnormal levels of the conventional CVD risk factors. While A1C adds minimally to CV risk prediction, those with pre-diabetes should have their conventional CV risk factors appropriately measured and managed. The diabetes prevention study studied the effect of an intensive lifestyle intervention and metformin on the development of diabetes in a cohort of people with an increased risk of diabetes, that is a pre-diabetes. After mean 2.8 years follow-up, 31% fewer metformin-treated individuals developed diabetes than individuals in the control group. 86% of the members of the metformin and placebo group were followed up and entered in the diabetes prevention program outcome study. The placebo was discontinued and metformin was continued in a dose of 850 milligram twice daily. And this is the timeline. There were 3 groups: the modified DPP lifestyle change program with self-management classes, modified DPP lifestyle change program, and metformin and only modified DPP lifestyle program. The 15-year follow-up results in the DPPO study, metformin-treated group showed significantly less development of diabetes, particularly in those participants who had a higher baseline of fasting, that is between 110 to 125 versus between 100 to 109. In those with A1C of between 6 to 6.4 versus less than 6%, and in women with history of GDM. The current focus is in 2016, the NIDDK, in partnership with the National Heart, Lung and Blood Institute, National Cancer Institute, began funding a 3rd phase proposed to last 10 years. So this is an ongoing study to find out if this metformin can save from complications. And we saw that lifestyle was 58% in the DPP study as compared to metformin. And this is the overview of the various trials in pre-diabetes lifestyle modification, right from darkening finish to diabetes prevention program, and even the studies have been done till 20 years. And what we find is that lifestyle intervention continues to have an effect even after 20 years, and almost to the tune of 58 to 69%. Then we have studies with pharmacological interventions like metformin, rosiglitazone, acarbose, and pioglitazone. The problem is that pharmacological interventions provide benefit, but with increased adverse effect with some drugs. But if you look at the ACNOS study, pioglitazone had an 81% risk reduction, 81% at the end of 3 years. Treatment with pioglitazone patients with IGT reduced the risk of diabetes, although this was associated with significant weight gain and edema. 18 participants were the number needed to treat for one year to prevent 1 case of diabetes. Moreover, we had certain pleiotropic effects like reduction of blood pressure, improvement in the lipid markers and the liver enzymes, and slowed progression of carotid intima media thickening, which is a surrogate marker. And the IRIS study, there was 52% reduction in progression from IGT to type 2 diabetes. So it is a wonderful drug, but it has to be used judiciously. So why metformin is today preferred over any other drug? The computer simulation modeling has shown that it can delay diabetes by almost 3.4 years and provides an 8% absolute reduction in the risk of development of diabetes over 30 years. And it reduces the cumulative glycemic lifetime exposure, delays or prevents the complications, and gives a better quality of life. It is inexpensive, cost-effective, and it has shown that it improves health outcomes. It reduces pro-inflammatory biomarkers and increases adenopectin. It is reasonable to expect that selective use of metformin in individuals with the greatest likelihood of benefit would yield even greater savings. And who are these patients? I just talked about it. This has been approved by Decision India for use in pre-diabetes. Today we have many supplements including cinnamon, chromium, alpha-lipoic, bitter melon, marketed for prevention of diabetes. Allowing the marketing and sale of these unproven therapies of diabetes prevention and denying high-risk individuals metformin, a proven and a safe, effective and cost-saving treatment is totally irrational. So who will benefit with metformin? Less than 60 years of age, BMI more than 35 kg per square meters, greater degrees of fasting hyperglycemia, and women with history of GDM. And this is known as benefit-based tailored treatment, which calculates an individual's absolute risk reduction as the difference between individual's risk without treatment and with treatment. So we have the various categories. You have to stratify the A1C into the three categories and see you can use lifestyle modification, losing 7% of body weight, physical activity, and then we have ultimately metformin and pharmacological therapies in selected cases and where bariatric surgery is also done. So what are the strategies for diabetes prevention? Mass awareness and education programs, which is being conducted by RSSDI, by Diabetes India, and all of us. Screening of high-risk patients. Identification of high-risk patients with pre-diabetes and stratifying them according to risk. And then, of course, lifestyle intervention, both non-pharmacological and pharmacological. If you look at the ADA 2022 guidelines, screening is must with an validated risk calculator, and I'll talk about the risk calculator which we should use, and especially in the subgroup who have obese or overweight and have one or more risk factors. For all people, screening should begin at the age of 35 years. That is what the ADA says, but in our situation, I think it should begin at the age of 25 years. And there are various the risk factors. I don't want to go into them because for us, all of us are at risk. Now, if the tests are normal, you should repeat screening at minimum 3 years interval. You can use anything, fasting, postprandial, OGTT, that's up to you. And when you're using OGTT, at least adequate carbohydrate should be given around 150 grams per day for 3 days prior to testing. In people with pre-diabetes and type 2 diabetes, identify and treat cardiovascular risk factors. That is very important, even in pre-diabetes. This is for the young children and adolescents, depending on the percentile BMI, and those in those HIV before starting antiretroviral therapy, at the time of switching, and 36 months after starting antiretroviral, you must do screening. Again, the risk factors, but then all of us are at risk. Now, this is the risk calculator that the ADA has recommended, but I think a much simpler one is the one that we have, the Indian Diabetes Risk Score, which has been developed by Dr. Mohan et al. And it is just 3 questions and 1 measurement and takes hardly a minute. What is the age of the patient, family history of diabetes, physical activity, and you just measure the waist circumference. And depending on these cutoffs, then you can have the total score. So anything over 30 is moderate risk and should be screened. And it's a very easy and very simple risk calculator that can be used in your clinic. Then there is a separate section on prevention or delay of type 2 diabetes in the ADA 22 standards of care. And they say monitor for the development of type 2 diabetes in all patients with pre-diabetes annually. And they want to say that you should basically give such a diabetes prevention program that patients achieve and maintain 7% loss of initial body weight, and you increase moderate intensity physical activity to at least 150 minutes per week. And then variety of eating patterns are there, but main thing is low calorie diet. The diabetes prevention program should be offered to all patients, and if needed, certified technology assisted help may be taken from those who are certified. Metformin, I have already told you what are the indications for the use of metformin. The only thing is that you must remember to measure vitamin B12 in those who are on metformin for a long time. Of course, screening for treatment and modifiable risk factors for cardiovascular disease should be a priority in these patients. The ultimate care goal is weight loss or prevention of weight gain, minimizing progression to hyperglycemia, and attention to cardiovascular risk and associated comorbidities. Of course, smoking cessation is very important, both tobacco and e-cigarettes. What about the role of vitamin D? This is a wonderful study which was done in more than 2,400 patients. One group, 4,000 international units vitamin D per day compared to a placebo, and there was no significant difference between the two. That means risk of new onset diabetes is not significantly lowered with vitamin D as compared to placebo. Now, this is very interesting that has come up just new. Wagner et al. Divided diabetes into 6 different subtypes. based on an intensive 25-year longitudinal study. And this, they further validated with the Whitehall 2 study. And this fits into the various categories that we must be looking for. And if you look at this, cluster 1, 2, and 4, they have very low risk of diabetes. In fact, 4 is the one who is overweight but with healthy biochemical parameters. And this was all based on the partitioning of variable derived from OGTT, MRI measured body fat distribution, liver fat content, and genetic risk. Now, if you look at cluster 3, this is, of course, 3, 5, and 6 are all high risk. Cluster 3, there is low insulin secretion, high genetic risk, high cardiovascular risk, high nephropathy risk. When you look at cluster 5, it has got high liver fat and insulin resistance, high cardiovascular risk, high nephropathy, and high mortality. Now, cluster 6 is a bit interesting. It has got high visceral fat, high renal fat, but very relatively low risk for progression to diabetes, but high risk of nephropathy and higher mortality. So what does this clusters in diabetes basically mean? So there are two types of groups. One who have an increased risk of complications without rapid progression to overt type 2 diabetes, and there are other duals who have an increased risk of complications with rapid progression to overt diabetes. And this is basically characterizing the metabolic heterogeneity that we see have in palliative. And this has got some potential therapeutic applications. Of course, there are certain limitations. Whether they are applicable to our ethnicity, we don't know. We have to do studies in India too. So what are the therapeutic applications? Cluster 1, 2, and 4, which are low risk, only intensive lifestyle modification. Cluster 3 will benefit from a standard aerobic exercise and dietary calorie restriction via reduction of visceral fat individuals. Cluster 5 are at imminent risk for diabetes. So they need a high intensity dietary and or lifestyle intervention aimed at weight loss and liver fat reduction. Cluster 3 and 5 have elevated genetic risk, and there is genetic predisposition is protective against development type 2 in cluster 6, as I said. So one should not forget that cluster 6 also, even though there is a low risk to development of diabetes, there are high risk of complications. So we must, preventive measures should be used even with a low glycemic progression. So what are the drugs? Metformin in cluster 3 and 5, role in cluster 6 a bit doubtful, since low risk of progression. Off-label pioglitazone, CV reduction proved possible roles in cluster 3, 5, and 6. We have emerging evidence with saroglitazole. Off-label high potential SGLT2 in 3, 5, and 6. But use of any off-label drug like Pio or SGLT2, I must warn you, there should be a judicious selection of patients, no contraindication, clear decision-making with the patient, education with the patient, and pharmacovigilance. And then only you start off-label if you want to save yourself medico-legally. So friends, to wrap up, the key messages are awareness and education right from nursery in schools, or perhaps even in infancy in the homes. It is very, very important. Our children should be taught lifestyle, how to live, what to eat properly, and discipline. That is very important. And then strategies to screen for pre-diabetes and assessment of individual risk factors is need of the hour. Pre-diabetes needs to be further classified because not all patients behave similarly. All patients with pre-diabetes, however, should be counseled for intensive lifestyle modification. Clustering of pre-diabetes is a very novel and emerging concept. And you must remember metformin in younger, more obese, more hyperglycemic, history of GDM, and possibly cluster 3 and 5. Looking beyond guidelines, Pio and SGLT2 appear to be of immense benefit in cluster 3, 5, and 6. And friends, I would like to end with a wonderful quote. The medical profession is the only profession that strives hard to wipe out its own existence by trying to prevent disease. Thank you.
Thank you, sir, for the wonderful talk. We are open for questions.
Sir, I have a question. You have talked in your presentation that lifestyle modification is the only non-pharmaceutical measures for prevention of diabetes. But at what stage we should start our lifestyle modifications?
Right from infancy. Our children should be taught.
But this is an
Regular exercise,
yeah.
avoiding junk food, avoiding watching too much TV. These things should be brought in right from with
These
our
days
children.
we are having epidemic of physical inactivity also as along with.
There is no sense in teaching people like us lifestyle modification, but at the age of 50, 60, 70, we are not going to do it.
Yeah.
It is the children who have to be taught.
That's why I was asking, it should be in adolescent, adult, or
Children, right. Why adolescence? Why wait till adolescence?
But
That is too late. You have missed the bus then.
But these days schools are also having online classes and more of IT subjects are taught rather than physical activity.
That is the problem. See, when I remember when I was in school in early 60s, every day we used to have 1 hour of PT
classes.
Physical training classes. And they have stopped now. I don't know why they have stopped in schools. I think it's a very, very compulsory thing.
So my question is, this side.
Yeah.
My question about metformin in IGT with a BMI of less than 20.
Less than 20.
20.
Doesn't matter. Still, there, metformin can be used if the fasting plasma glucose and A1C are on the higher side. As I said, even if the patient is non-obese, you will get benefit.
Oh, it's nice to have a cardiologist talking about diabetes. There are two things. Yep. You said about OGT in screening. Would you like to refine or comment?
Sorry?
OGT
Yeah.
for screening tool.
No, screening tool, I said you can use anything, fasting, postprandial or OGT. But fasting is the most easier to use. You can also do, there are certain high-risk patients who have got family history. They are very senior persons, they might come to you with a normal fasting. But you must remember that in the onset of even pre-diabetes or diabetes is the postprandial that rises first, and we often miss it.
Postprandial 2 hours, especially in Indian setup, it's a lunch.
So that is ideal.
OGT is a research tool. So
I 100% agree. OGTT is a research tool, but I said it can also be done if needed.
in a see, not in practice.
High risk.
Not in
High risk.
practice. Your question about this, what is that? School kids. See, this was analyzed by the White House. Barack Obama's wife, Michelle Obama, initiated a program called Let's Move, especially for the Afro-Caribbean kids. Unfortunately, he said, RSSI do nothing. None of our people do preventive measures. We are all in the pockets of the industry. We just treat with high cost medication. So only by this time, today at least there should be a walk in Goa. This is what they used to do in the past. Now the industry is running the conferences.
Over to the next lecture.
Thank you.
Dr. Virmani, one question to you.
Yeah.
Not a question, more like comment kind of a thing. You showed the therapeutic implications in clusters of pre-diabetes. Can those same therapeutic implications apply also once you get diabetes?
Yes, why
I
not?
think they would, right?
Why not?
So those kind of guidelines need to come out and more clusters need to be studied.
Correct,
Because
correct.
one size does not fit all. So if the therapeutic
Absolutely.
implications like you showed metformin.
See, we had those clusters in diabetes, but we were not sure about the application in the Indian
Right,
population.
right.
Dr. Mohan's,
Yes,
they did a wonderful
They
study
have done that.
and they found some subtle differences.
Right.
We are more insulin resistant and there is more of less insulin secretion.
Correct.
Similarly, clusters in pre-diabetes, again, this is a Western concept,
yeah.
and we need to have some
More and more.
trials in India to find out what is happening in the Indian population.
True. Thank you.
Thank you. Take
And
another.
one last question.
Yeah. Yeah.
Would you like to include fasting insulin level and HOMA-IR?
No. Not for routine clinical practice, only for research purposes. Only research purposes. Let us not waste patients' money. It is not going to add any further information to your treatment.
Thank you.
I strongly believe no investigation should be done which is not going to add to your treatment regimen.
Thank you.
So our next speaker is Dr. Neeta Deshpande. Her lecture has always been interesting and she's a great orator. She runs a diabetes center and a weight loss center in the city of Belgaum. She's a professor and HOD of medicine at Dental College. She's received the RSSDI fellowship in 2016 and she's been also as a member of the expert committee of RSSDI 2017 consensus guidelines. She's going to be talking on medical nutritional therapy, and over to you, ma'am.
Thank you so much. Good morning, everyone, and it's nice to be here again. I hope all of you are having this wonderful stay in this beautiful location. I have had the time of my life, and I'm sure you have too, and also with good academics. In the next 15 minutes, I'm going to be talking about some aspects of nutrition in type 2 diabetes. The nutrition advice has undergone a sea change in the last few decades that you can see. Earlier, we used to have diet charts, 1200 calories, 1600, 1800, and we used to hand them out to the patients, and they were like not customized at all, and it was like a one-size-fits-all kind. But we've come a long way from that, and now we talk about so many different things as far as nutrition is concerned. I'm going to show you data from this study called PRIDE, and I'm also going to show you my own data with a similar kind of product, with the same product in fact, but a similar kind of a study. So my disclosure is that I have been financially supported by this company for this particular talk only. So these are different anthropometric profiles of patients visiting a diabetic clinic. We just, in the last lecture, Dr. Virmani talked about different kinds of clusters, and we have different kinds of body types, and therefore we have different kinds of nutritional requirements. And you can see here that unlike what we thought, that our diabetic patients are not obese, you can see here the data tells you that we are indeed obese, and not just obese, but we also have abdominal obesity, and that is very well known. Now, the crux of the matter here is that why are we going so much behind nutrition when we have all these drugs in front of us? And it's just the numbers are just increasing. Every day there's a new drug, different classes of drugs, new pathophysiology, ominous octet, and what, dirty dozen, and unlucky 13. I keep hearing about more and more pathophysiology, more and more drugs coming in. But despite all of that, look at our figures. Not the literal figures, I'm talking about our metabolic figures. Literal figures are also bad, which I just showed you in the previous slide, and so are the metabolic parameters. So clearly, there is something that is missing, which means to say that despite all the best pharmacotherapeutic agents that we have, we are still not meeting targets. And the missing link here could very well be nutrition and lifestyle. So lifestyle modification becomes an important link between the person and pharmacotherapy and glycemic targets, and that is something that is not given enough of attention because it takes time, one, and second is old habits die hard, and lifestyle modification is not easy to achieve, and patients find it challenging. They don't know what they're supposed to eat, and we know that different people need different things, and the advice may not be customized, and therefore it needs a collaboration between the patient, the doctor, and the nutritionist so that everyone is on the same page. But whatever it may be, you know that we have pharmacotherapy, we have bariatric surgery, we have cutoff points for those, but you will see very clearly here that lifestyle modification, diet, physical activity is across the board. So whatever modality one might decide to adopt, lifestyle modification is a must, and it will continue right through the course of the disease, and that is why we need to talk about it. These were recommendations for obesity and weight management, ADA 2022, which are coming up. The ADA is coming up, but the consensus is already out. They talk about a high frequency of counseling. Not easy, expensive. We do not have enough expertise in India. Behavioral changes, extremely difficult, never talked about. We do not have enough people offering behavior counseling, but there is grade A evidence for that. Patients' preferences need to be taken into account, and most importantly, after the patient has lost weight, a long-term weight management program needs to be instituted, which never happens. One, because there is no such program in place in most centers of diabetes. Second is because patients do not come back and they're lost to follow up. So these are the practical problems. As I'm going along with this, I'm telling you along the way what we experience. So there are several challenges to dietary management, especially in India, and this, as you can see, is the most important. North, south, east, west, wherever you go, we have high carb, we have high fat, there is a lot of processed food coming in, refined grains, polished rice. Several things are there which our ancestors never used. They used it in the purest form and they worked hard. So though the food looks to be the same, it is not the same. It is highly processed, and because of that you find that a lot of metabolic diseases, disorders are coming in. You might have heard about endocrine disruptors. What are endocrine disruptors? Endocrine disruptors are those that are absolutely universally found everywhere in processed food, refined food, and in several other products that we use, and they disrupt metabolic pathways. And because of that, you can get metabolic disorders, and type 2 diabetes is one of them, cancer is another. And that is why, by and by, and you have seen evidence for this in the last 1 decade from 2011 onwards, when Roy Taylor actually popularized this. Rather than popularized, I will say brought it to the forefront. He talked about meal replacement. But look at this meta-analysis that involves 22 studies, 24 different interventions, and about 2,000 obese patients. And they found in this meta-analysis that the use of meal replacement-based low-energy diet is superior to just a food-based low-energy diet. And the reasons for this are many. The reasons mainly are that you are giving the right amount of carbs, calories, proteins, micronutrients, vitamins, etc. And that is why the meal replacements have actually worked. And this is what is going to be the crux of my talk, and also the study which I'm going to show you. So if you look at this particular study of 230 patients who use meal replacements, you can see that the A1C comes down very nicely. There is weight reduction by 5 to 7 kgs, low fasting plasma glucose, and there is significant reduction in blood pressure as well. So now we come to this particular study called the PRIDE study, which was an open label randomized controlled study to evaluate partial meal replacement program with ProHands D, which is the name of the meal replacement, targeting glycemic levels and weight control. In fact, in any such, either you call it a reversal of diabetes program or you call it any program, these are the two goals. One goal is weight reduction, second goal is glycemic control, very simple. So what they wanted to do was they wanted to evaluate the usage of this diabetic specific nutrition supplement along with a standard of care, which was the test arm, and the other arm was just standard of care without any meal replacement. And then they looked at the glycemic levels, the anthropometric measurement, lipid profile, and importantly, quality of life. Because when you're talking about lifestyle modification, please remember that quality of life becomes an extremely important issue because it is an everyday affair. It's not just popping a pill and forgetting about it. It is something that you do, something that you feel, because they say food is an emotion. And that is the reason that quality of life questionnaires become very important in all of these. And this was done for a period of 12 weeks. And you can see that the inclusion criteria are very simple. Males and non-pregnant females 18 to 65, type 2 diabetes more than 1 year with stable dose of oral drugs for more than a month, A1C ranging from 6.5 to 10, and a BMI between 23 to 34. So these were not highly obese patients, but they were overweight and obese both. And exclusion criteria, I won't go into the details. People who require anything very, very specific and who have any major comorbidities were not included in the study, and type 1 patients were not taken. Type 2 on insulin were also excluded in this particular study. And you can see that at baseline, they did the evaluations, and then they were randomized, and then the evaluation 2 was done at 12 weeks. Their primary endpoints, the first one I told you is glycemic control, of course, HbA1c, and the secondary endpoints were weight loss, the glycemic control, lipid profile, waist circumference, and quality of life. And safety events were hypoglycemia and any other adverse events. So this is the primary outcome. You can see here that the difference in A1C in the standard of care group at the end of 12 weeks was not significantly reduced, but whereas you can see that the p-value in the test arm, which received the meal replacements, it was substantial, a mean of 8.05 to 7.42. So glycemic control was achieved. Second outcome was weight. So you can see here that the weight reduction at 6 weeks and at 12 weeks, if you compare, you can see the huge difference in weight loss between the two groups. So clearly the usage of meal replacement as against just standard of care could give you good bit of weight loss. Waist circumference also was reduced in tandem, both at 6 weeks and at 12 weeks. It was highly significant if you had to compare it to just standard of care. Remember one thing, that standard of care therapy for diabetes can bring the blood glucose levels just to normal, and you can achieve a weight loss. This is what we see in practice of around 3 to 4 kgs, if followed very diligently. But if you want greater weight loss than that and greater glycemic control, then you have to go far beyond just regular standard of care that has been advocated in all these days. This is decrease in fasting blood glucose. You can again see that at both 6 weeks and 12 weeks, progressively, there was much better reduction in fasting blood glucose in the test arm with meal replacement as compared to the standard of care. The same holds true, especially at 12 weeks for postprandial blood glucose. So that also came down very nicely and was statistically significant. Now, this to me is a very important slide because it talks about quality of life. You're giving meal replacement, which a patient is not used to. You're giving food in the form of a liquid. Patient is not used to that. So what happens? So you can see here that people were adherent to their diabetes medication and they never felt hungry. Very, very important. Otherwise, adherence is not going to be there to the diet program. And they never felt, 66.2% patients never felt lethargic. And they had a good sense of well-being in 3/4 of the patient. This to me is a very important parameter when you are talking about giving a dietary lifestyle modification intervention to anybody. The safety analysis, none of them had any serious adverse events. It was safe and well tolerated, and they did not have hypoglycemia. So this is the post hoc analysis of that. And you can see that across the board, whatever be the baseline HbA1c, you can see that there was a very good reduction in HbA1c in all these patients who were given the meal replacement in addition to standard of care. Whatever be the baseline weight, there was good amount of weight loss in the test arm, as you can very well see here with the blue bars. And the BMI reduction in obese diabetic individuals at the end of 12 weeks was very, very significant with respect to the test arm as opposed to the standard of care, where there is some reduction. I told you, when there is standard of care, there is some reduction, which is good, but not enough. Waist circumference, something we are all interested in. We talk about the thin fat Indian. and therefore you see that there is a waist circumference decrease as well. So basically what they found was that partial meal replacement with a product like this resulted in significant improvement in glycemia, weight, waist circumference. People were satisfied with the taste, and it's a useful add-on to pharmacotherapy. And if you want additional weight reduction and a constant reduction in A1C, then perhaps this is something to think about in selected good patients. Now, this is my own data. Let me be very clear here that I have used Prohance D for this particular study. I have not been funded for this study. This is my very own study. So there is no funding from any pharma for this study. And I'm going to show you this. This was presented at the ACE in 2020. In this study, what we did was we aimed to study the impact of a VLCD, basically a VLCD on obesity indicators and other metabolic comorbidities. So it was given for 6 months. It included a structured diet plan, and low calorie of 800 to 830 calories was made up of 3 shakes a day. So we didn't do partial meal replacement. We did full meal replacement all the 3 times, and we assessed the clinical and biochemical parameters, 72 subjects. And you can see here the p-values with respect to weight, body mass index, waist circumference, hip, neck circumference, arm circumference, body fat, etc. And you can find that there is a significant difference over here. And the comparison of metabolic parameters before and after intervention, you can see here HbA1c at the end of the study was 7.3 to 6.7. Fasting came down, PP came down, blood pressure came down, lipids came down, and most importantly, liver fat was reduced. We found that so many of them were completely, the liver fat was completely gone. So that was the important part. So there was a significant impact towards reversal of metabolic disorders that was observed following a structured, very low-cal diet intervention in this cohort with the help of meal replacements. So the take-home message here is that there is no substitute for lifestyle modification. Second, there is no one size that fits all. Does this mean that I put every patient on meal replacement? No, I don't. So I have to choose my patient. I have to see whether he can do it. Behaviorally, is he motivated? Is he going to adhere to it? Can he afford it? These are all the different things that we do. Can we give him full meal replacement for some time till he loses weight if his weight is very high? Or does he just need a little help with just one meal replacement a day or a partial meal replacement a day? So it is not just giving a meal replacement. There's a science to it, and one has to do it very diligently, very judiciously, choose the right patient. But I'm sure that this is one modality which is actually our friend, a benefit to us, and we can show the outcomes to the patient. Thank you very much.
Thank you, ma'am. Any questions?
Yes, weight losing agents you can use, and now we have quite a few, actually one orally if you want to use. Yes, you can. So it all depends upon the body mass index, the patient profile, and you can always use it as an adjunct, definitely. It does help. My study is still ongoing. Actually, we are, this was 3 months data that I showed you, but the study is still ongoing and we are still analyzing these patients. The adherence rate, see, the meal replacement part does not go on for more than 3 to 5 months. That is only for that is full meal replacement. And then some of them go on 1 meal replacement a day for prolonged periods, just as a supplement. That is what we do actually. A full meal replacement is only for 3 to 5 months because it's a VLCD. But single meal replacement or just as a partial meal replacement, the adherence is excellent because patients have an alternative, especially when they travel. So they can just carry this and all they need is water to reconstitute it. It is so easy to do. So if a person is really motivated that he wants to keep his sugars and his weight under control and he carries this powder with him, he is good to go. No, there was nothing with that because it's not very high protein. I'll tell you, one full meal replacement if you take, it has about 10 grams of protein. So which is not very, very high protein. So even if you give full meal replacement, you're giving 30 grams of protein per day, which is still deficient. Yes? Yeah. No, 2 meals per day from the meal replacement, you're going to get 20 grams. So that we have a whole protocol. If you get 1 meal replacement, this must be the protein, like that. So there are any number of combinations that you can make, and a good qualified dietitian will be able to actually compute that. But generally, I try to give at least 0.8 grams per kg body weight of protein. Some of it may come from the meal replacement, and some of it you might have to supplement in other ways, because we are giving vegetables and other things along with that. So it's not just meal replacement. So that is also there.
Ma'am, what about the cost, affordability, and there are so many replacement therapies available, the kind of protein powders, some are soya proteins, whey proteins.
About this particular thing, yes, it is expensive. There is no doubt about it. So if a patient can afford, say, 1 meal replacement a day and is willing to take it on a long-term basis, there's nothing like it, but it's like one more medicine. Supposing you're going to give a GLP-1 receptor agonist and you talk to the patient, so you treat it as that. Don't treat it as food, treat it as medicine.
You said acceptance in our ethnicity as a drink is a little difficult. Have you tried, adding it in atta or in khichdi as a supplement?
No, this is not easy to do, but one experiment we have done is, we have frozen the meal replacement and it tastes good like an ice cream. So that is one thing that at our center with Prohance D, we have tried it out. I don't know if the makers are listening to it, but one other thing is that, I don't mind saying it here, the same people used to have soups, and their soups were very, very tasty, but I don't know for what reason it got taken off the market, and I'm hoping they'll bring it back. So you have a meal replacement in the form of a soup, and if you make a salad to go along with that, it's a full meal. And so the thing is that you sip it slowly. The other practical thing I can tell you, do not ask your patient to drink that as a milkshake. Ask him to take it with a spoon. So he takes a longer time to take it, like a soup, but a cold soup, a sweet soup, and it takes longer to have it. So this is some of the practical things that we have been doing at our place. We don't tell the patient, because if he drinks it up quickly, there's not enough time for the gut to tell the brain that you're full. So then if you take it with a spoon and then you do it slowly, it makes a lot of difference.
Dr. Neeta, my question is, how did you control other lifestyle factors like physical activity, sleeping,
yes,
time of sleeping?
So I'll tell you what we do at our center. We don't have a gym, but we ask them to join online classes for physical activity, or we send them exercise videos to be done at home, and an exercise prescription is changed every few weeks based on the person's capacity. See, a person who has a BMI of say 35, his capacity is much less than a person with a BMI of 30. So by the time he starts to lose weight, then we change the exercise prescription once again.
But I think that will bring some bias to your study, because you are giving regular prescriptions regularly regarding lifestyle, physical activity. That will bring a bias to your study. That's my point.
Not really. It won't give, it is more, it's not calories expended.
Oh, it is actually equal to all.
See, calories in and calories out is an outdated phenomenon. So you walk 1 hour and you are expending some 200 calories has no meaning, because if you come and have a breakfast, you have 300 calories. It's the in-between metabolic parameters that increase, that improve between exercise bouts. That is more important.
Yeah.
So that is the key. And ultimately, more than anything else, the patient has to do well. So the exercise prescription has to change.
Yeah, I agree with you on that. Okay.
Thank you. So you're talking about the timing. Well, the timing, now that is another different ball game altogether. We do this, and not in this particular study, but in general at my center. So there are people who want to do intermittent fasting. But having said that, intermittent fasting is not a different diet. It is just the timing. So intermittent fasting, what you're saying, or time restricted eating can be applied to any diet. It could be a meal replacement diet. It could be just a regular low energy diet. You can apply it to anything. Not in this study, we have not done intermittent fasting. No, no.
How long are the patients willing to continue this diet and this meal replacement?
How long?
Yeah.
See, basically, any lifestyle modification program is lifelong with tweaking as we go along the way. So we always tell them that lifestyle modification is lifelong. Of course, as I said, meal replacements, if you're giving all the 3 times, that will stop at 3 months or 4 months. There's a gradual reintroduction of food. Exercise changes. So it is lifelong. If they want to go on one meal replacement lifelong, there is no harm. We give Complan and Bonvita to children for years together. What is that? It's the same thing, right? So aren't we giving them 6 years, 8 years, 10 years? So it's not a question of how long. It's a question of
the
preference.
metabolic parameters return to baseline if they are not following the meal replacement.
Not like that. You will have to, if they don't want to follow the meal replacement, you will have to strengthen the lifestyle modification otherwise. And you would have to give them options of what they're going to have instead of the meal replacement. And that has to be monitored by the dietitian. It's not like you stop it and you put on weight. No, you can take care of it.
Dr. Neeta, can we have meal replacement options from the home available foods also?
That is what I said.
That's
You
why
can, if you do it from the home available food, it can be very difficult. One, I showed you a study where...
But compliance will be better if...
It may not be better. In fact, in our experience, if they're all working, they said, where will we prepare all this? How can we prepare it exactly, measure it, and then make it... It's not easy because you need then a very wide variety of foods to give you all those nutrients.
Because sometimes spending on non-pharmaceutical measures for diabetic controls are not taken so seriously along with pharmaceutical, and
that is why
after
I say
some months patients don't follow that meal replacement seriously.
I agree with you, but it has to be, that is the same question that she had asked also, that if they stop the meal replacement, then what next? So you will have to devise a method of doing it in another way, but the patient may actually find the meal replacement more convenient. And I'm not talking this because a pharmaceutical industry is here. This is what I have done for my patients, and I am not funded for that. There is no funding, but it is a principle of management that I believe in, and that is why I'm talking about it. But yes, home-based food can be used, but if you are looking to lose weight, you cannot do it in that fashion because the calories...
After losing weight, for maintenance purpose, for long term, you have to follow that diet plan.
No. As I said earlier, for maintenance, we introduce regular food. We teach them how to eat. And if somebody wants, they can go on a single meal replacement every day if they wish to. Otherwise, they are on home-based food, but it has to be nicely structured so that they don't put the weight back on again. I think we are running out of time.
How do you manage the weight plateau?
How do you manage the?
Weight plateau.
Weight plateau. You want that? You want me to answer that, or?
Yeah, please go ahead.
Weight plateau is not easy to answer, but the thing is that because the metabolic rate has gone down, the exercise has to go up, strength training has to go up, probably protein levels have to be checked. I mean, protein in the diet has to be checked and it has to be supplemented, and probably a change of diet also will help to get the weight plateau down, and you might sometimes then have to use medication.
I think with that we end this session. Thank you all, and thanks, ma'am. And I'd like to invite the chairpersons for the next session, Dr. Shashank Prabhudesai and Dr. Shubhda Kalvit. Kindly please take over the stage. Thank you.